dental and endophthalmitis.
Okay, good morning, and thank you all. I would like to thank the EVRS board. Special thanks goes to Ahmed Salam for the invitation. Number 4.
Get Mohamed Moghazy's slides, please.
Yes. Okay, so this is an interesting case that was present. Okay, a 9-year-old male with sudden onset of red eye 1 week earlier to presentation, family denying any history of trauma, and negative ocular and systemic disease history, presented initially to our uveitis clinic, and while they were doing their investigations and diagnosing him as an unknown form of juvenile uveitis, they started, of course, with the topical steroids and systemic steroids. This is his ultrasound and presentation, and you can see everything looks fine, and of course, some exudation, and there is subtotal exudative retinal detachment, which was clearly stated in the ultrasound at presentation. Again, the patient was on steroids, but he came 1 week later with this marked hypotony. Axial length is 18, and now the ultrasound shows an acoustic evidence of vitreous band extending from the anterior vitreous to the retina with inferior quadrant retinal detachment. And also, there was also signs of choroidal detachment and traction. So this is at the surgery. I took the patient to surgery next morning. I did lensectomy. There was no much of a lens, actually, but just a membrane, a fibrovascular membrane that bleeded a lot. You can see a lot of adhesions here. And then I started to remove the exudation and the hemorrhage, only to discover that this is not an inferior detachment. This is a closed funnel retinal detachment, and all attached peripherally at the fibrovascular membrane. So I was just wanted to try and open the funnel, and the bleeding, just cauterizing the fibrovascular membrane anteriorly several times. And at that stage I said, well, this is okay, just another traumatic case of retinal detachment. But the patient was denying history of trauma. Still, a lot of kids, they get trauma and they don't tell their parents. However, what's really interesting is, you will see in a second now, that I discovered that this is actually a traumatic endophthalmitis. And again, there was no wound to start with. And again, there was no history of trauma at all. The globe was intact at presentation, but you can see here the colonies of the microorganism. I don't know what it is, what's its nature, but this is what we see usually in postoperative endophthalmitis in some of the cases following cataract. And it was all over the surface of the retina and over the choroid under the detached retina. They're really sticky. Some of them can come up with suction. Some you need to puff off with a flute needle. And it's really a hectic maneuver just to try to remove them all as much as possible. Things went on like this, and then I used PFCL to stabilize the retina posteriorly. I started doing shaving of the peripheral fibrovascular membrane, trying to get as much of it as possible. However, this was we'll see in a second here. Yes, it's impossible to remove this membrane completely. I just try to remove as much as I can and cauterize, of course. And then I needed to do a couple of radial retinectomies to relax this retina. This was followed by laser and then PFCL silicone oil exchange. This is at 1 week post-operatively, and this is 1 month post-operatively. Visual acuity actually improved from hand motion to 1/60. And this is 6 months post-operatively. The silicone oil started to emulsify. Retina is still stable. Visual acuity is 360, nothing much, but the patient, of course, has chronic hypotony at 5 millimeter of mercury. So my question to the panel is, did we miss anything at the beginning to lead us to the diagnosis of an endophthalmitis, or what do you think happened in that case? Because I have the answer. And also, in those cases where you need to probably leave the silicone oil forever, what do you do about those cases? I mean, eventually the silicone will emulsify, it will fill the eye, and you need to exchange them, just keep them, just a shape. What do you do? Thank you very much.
Thank you, Mohammed. Very brave surgery, and your patients get the results. So regarding the keeping the silicone oil, we come from the retrograde question. So keeping the silicone oil, yeah, if that patient is only eye, I will keep the silicone, not, and if it is not giving any intraocular pressure, I will keep it. And if it is emulsified, I will replace it.
So we keep replacing the silicone oil
Keep
every now
replace
and then.
until unless it is only eye and this is the only precious eye and pressure is not raising. So I don't think there is any harm of keeping the silicone oil.
So, Mohamed, we still don't know what's the cause of this. Is that right? No trauma, nothing.
I
What
know,
do
I
you
will
think
tell
it
you at
is?
the
He
end.
knows,
I know.
he
Please,
knows.
please tell us.
Okay, the thing is, when I went in and I found that this is endophthalmitis and the patient's parents were denying any history of trauma, I remember that on the last ultrasound before I went in, they said there is a a vitreous tract, which is from anterior to posterior. And I have seen this because I treated a lot of those cases that, coming from rural areas of Egypt, where kids, unfortunately, they play with syringes. Okay. So the next morning, when I was with the parent consulting the first post-operative, they asked his father, was he playing with a syringe? He said, you know what? Now syringe. Yeah.
Needle injury.
Needle. So I said, yes, his brother, a few weeks ago, he hit him with a syringe in his cheek. I said, no, it was inside his eye. It went in and out and nobody noticed. And they were afraid to tell their parents, but the track, gave me the hint. So when I asked, yes, it was a needle track, a needle injury.
Actually, this happens in children quite frequently, I have to say that. And since it's unnoticed, they come with this picture. And I have some cases like this too. And the problem is that since they come late, they usually they already formed some ciliary membranes, which are quite bad. And the main problem is the hypotony in these issues. You have done so beautiful surgery and retina is so well attached, but those ciliary membranes usually cause hypotony. And as in your case, what I do in such cases is I always, as you did, try to clear as much membrane as possible and as early as possible. And then if the hypotony continues, I put an encircling band to support the ciliary body, because those
Where do
membranes...
you put it? Where do you have to put it very anteriorly then, right?
Yeah, just posterior to the insertion of the muscles. Okay, just posterior to it, and anterior encircling buckle. This is the first thing. Second, I put an capsule tension ring to the angle.
Yeah,
Maybe it may help a little
I
bit.
tried this before because
And
I
also
saw
triamcinolone.
a doctor from Turkey.
Yes,
put
Dr.
it-
Gökhan Gürel'in
Yeah, it
is
works
suggesting.
sometimes it doesn't. And
Yes.
regarding the buckle, actually, we do an UBM. And in those cases where it shows ciliary cleft, some of our glaucoma surgery colleagues, they suture it. But still, it doesn't work. So, I mean, ultimately, this patient, you leave the silicone oil, exchange it every now and then, and that's it. I mean, I really need an answer. Yeah.
Of course, this is not the 100% solution, but we can try these things.
Yeah.
And if the pressure increases a little bit, and I also use triamcinolone a lot for these cases, sometimes intravitreal, sometimes subtenon. And if I can see the pressure is like 10, 9, then I can think of removing the silicone oil. Before then, I just keep it. But it may come into anterior chamber and corneal problems and, all the story. But we are trying to prevent. Thank you for
Thank you.
bringing this.
Yes, Ahmed.
Ahmed.
I have a short summary I go with. If the pressure is a single digit or hypotony, no removal of oil. That's number one. Number two, oil is not a solution for hypotony.
I know.
Because using oil to treat hypotony, the oil, as Sangul was saying, it will come to the front. But I go with these two. And then I think hypotony is the end of game, unless there's a cleft, and I think that works perfect. Usually close the cleft, pressure goes up. But otherwise, it's the end of game.
Thank you.
Yeah.